Good afternoon, everyone. I'd like to welcome you to today's webinar. Our topic of discussion will be on duct-dependent congenital heart defect. Our presentation will be by Dr. Zadok Obare. He's a fellow in pediatric cardiology and based at Kenyatta National Hospital. Dr. Zadok, please go ahead and start your presentation.
Good afternoon.
Good afternoon.
You can see my screen?
Yes, we can see your screen and we can hear you clearly.
Yeah, thank you. Thank you, Dr. for the introduction. We will be discussing the next 1.5 hours on duct-dependent congenital heart defects in neonates. So these are conditions which will present as emergencies in the neonatal life and will warrant an intervention to ensure survival of that neonate or infant. This will be my outline. We'll have a brief introduction, then we'll go through the various ways the duct-dependent lesions will present, classify them. Then we shall also look at the possible causes and or the possible the lesions that cause, which are classified as duct-dependent congenital heart defects, and some of the interventions and management options that will be key in improving survival of these neonates. So as an introduction, congenital heart defects, the incidence is 8 to 10 per 1,000 live births. Or you can, easier to remember that 1% of the total live births, that baby might have a congenital heart defects. And a third of these lesions, a third to a half, will be classified as critical congenital heart defects. By critical, I mean these are defects that will need an intervention at least within the first year of life in order to improve your survival outcomes. So duct-dependent congenital heart defects refers therefore to abnormalities in which the patency or the permeability of the ductus arteriosus is necessary to maintain systemic perfusion or pulmonary circulation, pulmonary perfusion, and also allow for mixing where you have a situation where there are parallel circulations. And we'll touch this in more detail as we move on. So in other words, there are three categories, therefore, of duct-dependent lesions. Those which depend on the ductus arteriosus, which is a vessel important in intrauterine life that ensures that there is, because in intrauterine life, there is high pulmonary vascular resistance, and therefore the blood is shunted from the pulmonary artery back to the aorta. And this vessel, during intrauterine life, and this vessel normally will close shortly after birth. But when it closes, in some specific lesions, that will impair your perfusion of the systemic circulation. That's perfusion through the aorta to the rest of the body, or pulmonary circulation to the lungs, or conditions where there is parallel circulations, which, as I've said, we are going to dwell more on that as we move on in this presentation. So these lesions, their presentation varies and dependent on the time at which this ductus arteriosus will be closing. As I've said, it will undergo closure shortly after birth. The risk of mortality and morbidity worsens in these conditions if there is a delay in diagnosis. So I'll give some scenarios of how some of our babies will present who have these duct-dependent lesions. First baby, 3-day-old, born at term, an APGAR score of 899, then present with cyanosis. On examination, the main findings were you found an ejection systolic murmur over the left upper sternal border. The adult will call this the aortic area. Saturations of the right upper limb and right lower limb, both of them are about 73%. This child is put on continuous positive airway pressure CPAP or continuous positive airway pressure ventilation, but the cyanosis does not improve. Another case or another patient, 12-day-old, born at term, score 7, 8, and 9, but it's noted to be cyanotic with increased work of breathing. Examination, there's no murmur. Pulse oximeter, right upper limb and right lower limb, 53%. Again, it's put on CPAP with minimal improvement. A chest X-ray is done, and you see an egg on a string appearance. So what could this be? Then a third baby, 4-day-old, born at term, scores 7, 8, 9, is noted to have cold extremities, so extremities of the feet, the hands. Then there's delayed cup refill time, weak brachial and femoral pulses. On examination of the cardiovascular, especially on auscultation now, there is no murmur is detected. And the pulse oximeter is difficult to pick in all the limbs. So what could this be? Then a 5-day-old, last example, born at term, delivered, the cries immediately after delivery, noted also to have cold extremities, delayed cup refill time. But unlike the third baby, this one, the brachial pulses are strong, but the femoral pulses are weak. On examination, a harsh murmur is picked on the right upper sternal border. This is what the other, we call the aortic area. The previous one was the pulmonary area. Then the pulse oximetry, right upper limb saturation at 96%, right lower limb saturation of 76%. So a difference of saturation of the two limbs of 20%. So ask yourself what this could be. And this is how these babies will present. They present initially well at birth, then they deteriorate rapidly and go into circulatory collapse or features of reduced flow to the lungs if no intervention is undertaken. And most of these lesions, once the PDA closes, they become, they are incompatible with life. So survival is greatly hampered in these babies. So what is the ductus arteriosus that we have been talking about? As I said earlier, an important structure in the fetal life, during intrauterine life, that diverts blood from the high resistance pulmonary circulation to a low resistance descending aorta and the placenta. So in fetal life, pulmonary circulation is a high resistance circuit. The systemic is a low resistance circuit. Then once it's delivered, the placenta is cut off from the baby, the lungs expand, then the opposite occurs. Slowly there is drop of the resistance of the pulmonary circulations, and there is rise of the systemic vascular resistance. And therefore now this flow turns into from the aorta into the ductus. Of course, especially in babies where this ductus arteriosus does not close. Otherwise, functional closure occurs, as we're going to see, followed by anatomical closure of the ductus arteriosus. And whenever that ductus arteriosus does not close, is what we call a patent ductus arteriosus, or commonly what we call a PDA. So patency of the ductus is maintained in intrauterine life, as it is an important structure by prostaglandins. Prostaglandins that are, these are prostaglandins that are synthesized in the vascular wall of this vessel. So prostaglandin E1 and prostaglandin E2. So functional closure occurs within a few hours after delivery due to constriction of the vessel. Then anatomical closure with fusion now of the walls of the ductus arteriosus, which converts that ductus into ligamentum arteriosum. If that does not close, then we end up with a situation of we call a patent ductus arteriosus, which itself, of course, later in life, or rather even during the neonatal period, if it's a large PDA, it can also be problematic on its own. So the factors which will delay closure of the ductus arteriosus, it tend to be more common in the preterm babies, so prematurity, and conditions which will result in hypoxia, like prenatal asphyxia, and respiratory distress as well. As some of the examples, the common examples that result in delayed closure of the ductus arteriosus. So when you look at these ductal-dependent lesions, we look at them in three categories. One is there is duct-dependent pulmonary circulations, conditions in which this ductus is key to ensure there is continuous flow or continuous circulation into the pulmonary vessels, and therefore perfusion to ensure perfusion into the lungs. So examples of these conditions include critical pulmonary stenosis, the trilogy of Fallot with severe right ventricular outflow tract obstruction. So there's a third one there which has been matched to the second one, pulmonary atresia with ventricular septal defect. Then the fourth is pulmonary atresia with intraventricular septum, then severe Epstein anomaly. Then you have lesions in which the ductus is important to ensure there is continuous circulation into the aorta. This includes hypoplastic left heart syndrome, critical aortic stenosis, interrupted aortic arch, critical coarctation of the aorta. Then the last group is where there is parallel circulation. Let me go into to explain what this means. In this situation, and we see this in patients who present with transposition of the great arteries with an intact intraatrial septum and an intact intraventricular septum. So for these patients, you find the aorta, instead of coming from the left ventricle, the aorta rises from the right ventricle. Then the pulmonary artery arises from the left ventricle, when in normal situation it will arise from the right ventricle. So therefore, the blood that is coming through the superior vena cava or an inferior vena cava into the right atrium, then goes into the right ventricle, then is pumped, instead of going through the pulmonary artery into the lungs, it goes through the aorta again and goes back into systemic circulation. And then you have blood that is coming from the lungs through the pulmonary veins, usually 4 pulmonary veins, then comes the left atrium, then through into the left ventricle. Instead of going from the aorta, then that blood goes to the pulmonary valve, which has been transposed, and back into the lungs. So therefore, you have 2 parallel circulations, which without a level where there is mixture of blood, to ensure that this blood that is going through the systemic circulation, which is poorly oxygenated, is able to mix with the well-oxygenated or the well-oxygenated blood that is coming into the lungs. And therefore, this baby will present with cyanosis as a result. So let's look at what we mean by the others. Critical pulmonary stenosis. Critical pulmonary stenosis is a situation where there is stenosis of the pulmonary valve, such that there is minimal forward flow from the right ventricle or right ventricular outflow tract into the pulmonary artery. And therefore, the PDA becomes important because there's minimal flow of blood from the right ventricle into the pulmonary artery. PDA becomes important as it shunts blood from the aorta back into the pulmonary vessels or the pulmonary arteries of that neonate or of that patient. And the trilogy of Fallot, if you remember the components of the trilogy of Fallot, they present with a large VSD, right ventricular hypertrophy. They present with right ventricular outflow tract obstruction. So in situations and overriding aorta. So in situations where again there is severe obstruction either below the valve or the infundibular obstruction or at the valvular level or even supravalvular level, then you end up in a condition where there is again very minimal forward flow into the pulmonary artery. And therefore, to ensure circulation into the lungs, PDA becomes important again as it shunts blood back into the pulmonary vessels. And when it closes, then this child is likely to present with features of marked reduction of flow into the lungs. So there is a bit of overlap, pulmonary atresia with VSD. So pulmonary atresia with VSD, there is a complete atretic pulmonary valve. So it could be there's a membrane there, or there's a muscular obstruction at the right ventricular outflow tract, such that there's no forward flow from the right ventricle into the pulmonary artery. And therefore, survival of these babies is dependent on adductors supplying the pulmonary arteries. Sometimes maybe about 30%, instead of adductors, you might find some of these babies having what we call a collateral, a major aortopulmonary collateral vessel. So these are vessels that will arise from the aorta, then supply the lungs, supply the pulmonary vessels. But majority of them, 70%, it will require adductors arteriosus to supplying those native pulmonary arteries. So if it has a VSD, then we say pulmonary atresia with VSD. If it is intact, then we say pulmonary atresia where there is no VSD with an intact intraventricular septum. Last is severe Epstein anomaly. In severe Epstein anomaly, there is downward displacement of the tricuspid valve, as well as tethering of the tricuspid valve leaflets to the right ventricle. And as a result, these patients, they tend to present with reduced flow of blood back into the pulmonary circulations, and can present early on with features of cyanosis as a result. And they also will need adductors to ensure early on that there is continuous flow into the pulmonary circulations. Then systemic circulations. These lesions, we tend to see them more in the male babies, especially the critical coarctation of the aorta. Ratio of male to female can be 2:1. So what do we mean by them? Let me just give again an explanation. Hypoplastic left heart syndrome is not a single disease. It's a group of disorders that are characterized by atresia. In other words, there's complete obstruction at that valve. With this valve is mitral valve or the aortic valve, or hypoplasia of the aortic valve and the mitral valve. So you can have, for example, a patient presenting with mitral valve atresia with stenosis of the aortic valve, or mitral valve atresia with aortic valve atresia as well. And also they tend to have an hypoplastic left ventricle. This condition, even in developed countries, is fairly difficult to manage and accounts for a large percentage, slightly over 20%, some of 23% of neonatal deaths with congenital heart defects in the first week of life in the developed world. So even in our setup, we tend to present a management difficulty. The other one is where there is obstruction, commonly at the valvular level of the aortic valve. Again, there is minimal forward flow from the left ventricle into the systemic circulation, rather into the ascending aorta, then to supply the head and the limbs. And as a result, it requires the doctors to shunt the blood from the pulmonary circulation back into the systemic circulation to ensure that there is some degree of circulation into the systemic vessels. Then the third one is where there is interrupted aortic arch. In this condition, there is complete separation of the ascending and descending aorta. If you remember your anatomy at the arch of the aorta, there's ascending aorta, then it divides, it gives off branches. The first branch normally is the brachiocephalic or the innominate artery, which then will divide into the right common carotid and the right subclavian artery. Then the left common carotid is the next branch to come out, and then the left subclavian will come out. So in this situation, as the artery ascends, there is complete separation of the two. So there's no flow from the ascending aorta to go through the arch of the aorta, then into the descending aorta. So you can have separation either between below the subclavian artery, left subclavian artery, or between the left subclavian artery and the left common carotid, or between the left common carotid and the right subclavian, or rather the right, or rather the innominate artery. And this also fairly difficult to manage, but will present therefore the circulation into the descending aorta is purely dependent on the ductors supplying blood, shunting blood from the pulmonary circulation to the systemic circulation to ensure there is continued flow into the descending aorta. Then coarctation of the aorta, which is the more common one of these lesions, refers to narrowing of the arch of the aorta, commonly at the level of the ductus arteriosus. And this narrowing can be discrete, in other words, narrowing at that level, or the narrowing can extend into the area we call the isthmus, which is the area between the ductus and the left subclavian artery, or it can extend into, and this is fairly common in the neonates, where it will extend from the isthmus and narrow will continue into the transverse arch. So therefore, if there is reduced flow, there's reduced minimum forward flow from the ascending aorta through the narrowed segment in a coarctation patient, descending aorta circulation is going to require a ductus arteriosus supplying it to ensure survival. And its closure, therefore, tends to be detrimental to survival of the newborn. So this is more of a repetition of what I've been explaining. Duct-dependent pulmonary circulation will present with decreased blood flow to the lungs, obstruction of flow into the pulmonary vessels results into increased right atrial pressure, with shunting of blood from the right atrium to the left atrium at the level of the patent foramen of Weil. PDA is the only source of blood flow into the lungs or to the pulmonary vessels. And these patients present with increased work of breathing, low saturation levels. Dominantly, this is the main finding, is cyanosis. They present mainly with cyanosis, so darkish discoloration of the tongue, extremities as well. So cyanosis becomes the main presenting feature. Then oligemia if you are to do a chest X-ray. Systemic circulation, on the other hand, they present differently. So once the ductus are closed, then the patients tend to go earlier into heart failure because the neonate is not able to bring in the compensatory mechanisms. The LV may not have hypertrophied so that it can overcome the increased resistance at the level of obstruction, the afterload. The LV for neonate, if you remember your physiology, something called Frank-Starling mechanism may not be able to be compliant and employ those mechanisms to overcome that resistance. So this patient is going to heart failure, and that failure in these infants, they present with hepatomegaly, so increased liver span on examination. They present with respiratory symptoms, poor perfusion of the extremities, so-called extremities, delayed cup refill time. They are acidotic as a result of metabolic acidosis due to hypoxia that is a result of poor systemic circulations. And therefore present with systemic hypoperfusion of features of shock, features of heart failure, decreased lower limb blood pressure, especially if it is a coarctation of the aorta or interrupted aortic arch, diminished femoral pulses as well. Then the other one is the TGA, which I explained earlier, especially in a setting of intact intra-atrial septum, intact intraventricular septum, and there is parallel circulations. This becomes incompatible with life and needs the presence of a lesion where mixing of these two parallel circulations can be able to occur. And this can either be at PDA level, which that's why it becomes a duct-dependent lesion, or if there's an ASD, which sometimes, as we are going to see, we need to create an ASD to ensure as a palliative intervention to ensure survival, or some of the babies might present with a VSD. And therefore, if they have a VSD which is not restrictive or rather non-restrictive, that might make them, they may not go into early cyanosis as a child where there is intact of intraocular septum, intraventricular septum, then the ductus is closed. So it presents also with cyanosis as the main findings. So back to our cases, the 3-day-old who scored well at birth, main findings being an ejection systolic murmur, cyanosis, ejection systolic murmur of the left upper sternal border. These saturations of both the right and the lower limbs were low. The main pathophysiological mechanism is the insufficient pulmonary blood flow. And this is the main presenting you will see in critical pulmonary stenosis. So that baby had critical pulmonary stenosis. Of course, a baby also with tetralogy of Fallot, with severe right ventricular outflow tract obstruction, will also present in a fairly similar manner. The second baby, who had an X-ray with a egg on a string, scored well at birth, but is cyanotic, increased work of breathing, saturations of both the upper and the lower limbs, or what we call preductal and postductal saturations at 53%, no change on CPAP, egg on a string. The mechanism is a separate or rather parallel circulation, what we call a TGA or a detransposition, in which the aorta is anterior and to the right in relation to the pulmonary vessel, so TGA. Then the third baby who came with features of shock, you couldn't even pick pulse, you couldn't pick saturation, cold extremities, delayed cup refill time, weak pulses, and the finding with no murmur. So classical presentation of hypoplastic left heart syndrome. Then the last baby, born at home, cried after birth, had cold extremities again, delayed cup refill time, but the brachial pulses were fairly palpable, strong, but weak femoral pulses, difference of saturation between the upper and the lower limbs. Then that baby, the main pathophysiological mechanism is insufficient systemic circulation due to a critical coarctation of the aorta. So look at it in those three mechanisms: insufficient pulmonary blood flow, insufficient systemic blood flow, and separate and parallel circulation as a result of mainly transposition of the great artery with intact intraatrial septum, intraventricular septum. And all these babies are presenting once the ductus arteriosus has closed or is closing. Of course, you can have differential diagnosis as well to these babies. Like, it's important to always rule out pulmonary hypertension of the newborn, especially in a baby who with perinatal asphyxia, or rather born post-datism, meconium aspiration. Neonatal sepsis, especially in our setup, can also present with features of reduced circulation. A preterm lung pathology, for example, a preterm baby who might have intrapulmonary hemorrhage. Another condition is obstructive, which can present early on, also obstructive total pulmonary venous connection. Okay, total anomalous pulmonary venous connection also presents metabolic disorders, especially hypoglycemia, can present in this manner as well. Methemoglobinemia is a condition where instead of the hemoglobin having a normal ferrous, it has ferric. So if ferrous was Fe2 plus, ferrous was the 3 plus, and therefore then they tend to these patients can also present with cyanosis. And in situation where there is a pulmonary hypertension of the newborn with an cyanotic congenital heart defects, where there is shunt reversal, either the atrial, for example, an atrial septal defect or ventricular septal defect, where the shunting, normally it occurs from left to right, but now because of the especially severe PPHN or severe persistent pulmonary hypertension of the newborn, shunting will occur at the atrial or at the ventricular septal defects level due to increased pressures, of course, in the pulmonary circulations. So in your history taking, of course, some of the a history that is suggestive of a baby born did well at birth, then start deteriorating soon after. But other additional findings, for example, if there is family history of congenital heart defect, the risk tends to be increased. If, for example, if the mother has history of, or rather was either there was an intervention for congenital heart defect, the relative risk compared to the normal population is 5. If the father was affected, had a history of congenital heart defect, the relative risk is 3. This was a major finding in Denmark, where they followed babies from 1977 to 2011, and it's a big study they carried over the years to see the risk of developing congenital heart defects. Consumption of alcohol increases the risks of congenital heart defect in the developing fetus. So they might present with fetal alcohol syndrome. Also, some other drugs which could be teratogenic, especially if used in the first trimester during pregnancy. If there is evidence also from history of from either an ultrasound or fetal echocardiography, that will help you in picking it out early. And as I said, an inventive delivery from history, then cyanosis or systemic circulation impairment soon after the duct has closed will be a major finding in history taking. So they usually are symptomatic at birth, as I said, then they are till discharge. Then the symptoms detection remains a challenge as they are normally normal at birth, okay? And we are not able to do prenatal screening in most of our workplaces or our hospitals to be able to pick them out earlier. And therefore, as we are going to see, an effective tool to ensure that we are able to pick out these babies early is doing a pulse oximetry. And this has been recommended by the American Academy of Pediatrics. To ensure it's a good tool that can be able to pick out critical congenital heart defects, and therefore resulting into an intervention to ensure survival of these children. Babies might also present later on with other clinical features like difficulty in feeding, where they take too long to breastfeed. They pause during breastfeeding. There's decreased intake in breastfeeding, and therefore, as a result of that, they present with poor weight gain. They sweat a lot during breastfeeding. They are irritable, or they present with cyanosis. They might also present with features of respiratory distress, increased work of breathing, fast breathing, intercostal, subcostal recession, or cough, or even wheezing, or decreased babies will be lethargic, so decreased activity and excessive sleeping. General exam, as I said, cyanosis, especially for relations with parallel circulation and reduced flow of pulmonary circulation, increased work of breathing, and features of heart failure or even shock for babies who present with systemic circulation dependent, PDA dependent conditions. Other findings, of course, the heart rate, if it's less than 90 or above 160 neonates, that is abnormal. And a tool we need to also increase its utility is an ECG. Can also pick out arrhythmia, and we are going to see its utility as we continue with this discussion. Precordial activity, if the heart on the right, then what we call dextrocardia, there might be other associated complex congenital heart defects. A parasternal heave on palpation will suggest right ventricular volume or pressure overload, and increased apical activity will suggest left ventricular volume or pressure overload. On auscultation, a single second ultrasounds is likely to point out to pulmonary atresia and also truncus arteriosus. Mamas, you can have innocent mamas, of course, in the neonate, or rather in the infant. But if this mama is of grade 3, remember grading of mama, grade 3 is allowed mama or higher. When it has a 3, it becomes grade 4. Or a mama that is pansystolic, or a mama that is diastolic, or a mama that is loudest at the upper left or upper right sternal border, or at the apical area, then that mama will warrant at least evaluation, for further evaluation by pediatric cardiologists. Then, however, absence of a mama does not rule out critical congenital heart defects. As we have seen, babies with transposition of the great artery with intact intraventricular septum will not have a mama, as well as babies with hypoplastic left heart syndrome. Chest exam, increased work of breathing by head nodding or head bobbing, nasoflaring, tachypnea, tachypnea and grunting. I think we mentioned this, hepatomegaly. Try and get a liver span rather than measuring the distance below the costal margin. As pulmonary conditions like meconium aspiration, especially in the neonate, will flatten the diaphragm and give you an erroneous hepatomegaly, where you might think that the liver span is increased, but rather it's because of the hyperinflation of the lungs, with the liver being pushed down by a flattened diaphragm. A midline liver, rare, but might point to heterotaxy. Heterotaxy are those conditions where there is, for example, laterality disorders, where the organs are more to the right or more to the left. Also, other features which will also, if there are other extracardiac abnormalities, there are syndromes which results in other anomalies, for example, VACTRIL, vertebral, cardiac, tracheoesophageal, renal abnormalities, or even chromosomal disorders like trisomy 21, trisomy 18, Turner syndrome, trisomy 13. So if a baby has those features, also there is increased risk of a critical or a congenital heart defect. Your key investigations are blood gas. If a baby is presenting with cyanosis, a blood gas will be important. And from a blood gas, if you pick out metabolic acidosis, will indicate that there is poor systemic perfusion. An elevated PCO2 from a blood gas is mainly due to pulmonary disease or pulmonary congestion. So back to our screening, our key screening tool, which can be useful, can be key, and it's in our guideline, national guidelines now, where you do a pulse oximetry. You check your saturation, ideally 24 hours after birth. So 24 hours after birth, or if a baby has to be discharged within the first day of life, then try to do it as late as possible, if that is being planned. But most of our deliveries, even the spontaneous birth delivery, they go home the following day. So at least 24 hours after, then you do it. And if it has to be done early, then it should be repeated. So a pulse oximeter, of course, is your key tool. And you check the right upper limb, preductor. So in other words, that this vessel comes out of the transverse side of the ascending arch before the ductus arteriosus has been given. Then the vessels beyond the ductus are postductal. So you check either foot, either the right or the left lower limb. And you do screening at both locations simultaneously. If this is not possible due to constraint, then you do it in direct sequence. Ideally, this should be done by qualified and trained personnel. And to ensure there is accuracy, always correlate your saturation with the heart rate. Because if the heart rate is not inconsistent with your clinical exam, for example, when you count the heart rate, then that might also mislead you. So when is it positive? If at any time you fulfill one of these criteria, if you find the saturation is less than 90% in either preductor or postductor, then that is one who has failed the oximetry screening test. If the saturation is less than 95%, after 3 measurements 1 hour apart, then that is one who has failed the screen. And if there's a persistent difference of more than 3% between the preductor, that's the right upper limb, and the lower extremities, if there's a difference of more than 3%, then again that one has failed the screen and warrants an evaluation by pediatric cardiologist. I'm trying to emphasize, use a pediatric cardiologist. At times I've seen where, and I'm not being against our echo technicians, our adult who do echocardiography or evaluate adult patients, they may not be able to pick some of these rare disorders. So if you are in a situation, refer to a pediatric cardiologist. Limitations, of course, of this, it may not be able to pick cyanotic lesions, the most common being the ventricular septal defect, and a negative result does not rule out a significant or rather critical congenital heart defect. So to revise again, child is born, then 24 hours after 24 hours of delivery, or shortly before discharge, if it has to be done early, before 24 hours, and ideally they plan to repeat it. If the saturation is less than 90%, either in the preductor or postductor limb, that's the right lumbar, the right upper limb, and the right or the left lower limb, respectively, then that one has failed the screen. If it's between 90 and 94%, or there's a more than 3% difference in saturation between the preductor and postductor limb, then repeat the screen after 1 hour. If it drops back to 90%, that one has failed the screen. If it's still maintains 90 to 94%, or there's still that difference of 3%, repeat it after. If again, the same ratio, 90 to 94%, 3%, after 3 separate measurements, 1 hour apart, then that one has failed the screen. If at all it drops to 90% in either of the limbs, or rather preductor and postductor limbs, and that one has failed the screen and needs to be evaluated as well for a critical congenital heart defect. So, but of course, if saturation is above 95% at any point, or above of the difference between the preductor and postductor saturation of oxygen is less than 3%, then that neonate has passed our screen and can be safely discharged home, of course, with the mother. Another test which we may not utilize a lot in our setup is the hyperoxic test. It's keen distinguishing cardiac from non-cardiac causes of cyanosis, especially lung pathology. So in this test, of course, you'll do a blood gas. So you give the patient, you put the patient on 100% oxygen for 5 to 10 minutes. Then you do a blood gas to measure the partial pressures of oxygen in the preductor as well as the postductor, the lower limb, from a lower limb artery. Then that helps you in differentiating cardiac and non-cardiac causes of cyanosis. It might have limitations. It may not be able, for example, conditions like pulmonary disease with massive pulmonary pathology or massive hemorrhage, for example, may not respond to oxygenation as well. But when you do that and you measure partial pressure of oxygen and you find it's more than 300 millimeters of mercury, then that is normal. Between 150 and 300, then that's likely to pulmonary disorders or central nervous disorders, which affect your respiratory center in the brainstem, or methemoglobinemia. If it's between 100 and 150 millimeters of mercury, likely to be PPHN, persistent pulmonary hypertension of the newborn. If it's less than 100 millimeters of mercury, then likely that you are dealing with a cardiac congenital heart defects. Other investigations is a chest X-ray. And in a chest X-ray, key is to look at the size, of course, of the heart. Remember, most of these X-rays are anterior-posterior views. So heart size is normally 2/3 of the cardiothoracic ratio, not 50%. We get a lot of referrals based on the 50% at our National Referral Hospital. Also look at the shape of the heart. Remember, neonates tend to have a large thymus, and therefore the superior mediastinum is likely to be enlarged. That should not be aware of that as you read the chest X-ray, and look at the pulmonary vascular markings. So for heart size, left-sided obstructive lesions might present with cardiomegaly, as well as patients who might also present with the enlargement of the right heart border, or of the right sided border of the heart, especially if there's dilated right atrium. And we are likely to see this in the tracheophalo, pulmonary atresia with an intact VSD, and Epstein anomaly. An enlarged right ventricle will result into, due to hypertrophy, it results into the apex of the heart being upturned. And if there is concavity of the pulmonary bay, then that's what the classical boot-shaped, which tends to point to the tracheophalo in most of our patients. So these are some of the X-rays. Some of the X-rays for example, egg on a string, a narrow mediastinum, then the heart takes the shape of an egg. A narrow mediastinum because of the transposition, where the aorta tends to be anterior now and posterior, anterior to the pulmonary artery, which is posterior. And that appears to be like an egg that is hanging on a string. So this tends to point to transposition of the great arteries. In a situation where there is marked cardiomegaly, where the heart appears rounded and or box-like, and almost looks like it fills the entire cardiac, or rather the thoracic cavity. We see this in severe cases of Epstein anomaly, cause also oligemia and enlargement of the right atrium as well. Then this is what I said earlier, the apex beat is upturned due to right ventricular hypertrophy. And then the pulmonary bay area is normally here due to a reduced, due to a reduced size of the pulmonary artery. So there is concavity of that area, and that gives you a classical boot, especially in the setting of reduced pulmonary vascular settings, oligemia. Then the last example is total anomalous pulmonary venous, an X-ray of a total pulmonary venous connection. This is you see this there are 3 types: supracardiac, where the pulmonary vessel connect above the heart. So they connect the systemic vessels above the heart. And in this patient, you have the pulmonary veins normally will form a confluence, and that a vessel which we call a confluence, and that confluence rises on the left to drain either more commonly into the left innominate vein, and the left innominate vein then will join the superior vena cava to drain the right atrium, and therefore you tend to see enlargement on the left because of that vertical vein that rises from that confluence of pulmonary veins. And then on the right superior vena cava is also enlarged. And of course, then you see the heart shadow below. So it gives you a figure 8 appearance. We tend to see this in total anomalous pulmonary venous connection of supracardiac type that's mainly obstructive in nature. You can also have others where they connect directly at the heart level, mainly through the coronary sinus, or even below the heart through the inferior vena cava and the portal veins. So these are some of the classical things that can raise an alarm and point to you that you are dealing with a critical congenital heart defects. ECG, as I said, it's also important. The ECG of a neonate, again, you look at the rate, you look at the axis, you look at the rhythm, you look at the intervals, you look for chamber enlargement or hypertrophy. Normally in a neonate, because in fetal life, there is dominant right ventricle, which is which has to pump blood against a high resistance circulation, which is the pulmonary. You tend to have right axis deviation and dominant right ventricular forces, which will normalize as the baby grows up. However, lesions which give you a small right ventricle, for example, pulmonary atresia with an intact intraventricular septum, or tricuspid atresia, you are likely to see left axis deviation. LV strain, we tend to see this LV strain where there is which points to left ventricular hypertrophy, especially in critical aortic stenosis, not common in coarctation of the aorta and interrupted aortic arch. Right atrial enlargement, you'll see with tall P waves, especially on lead 2. And that will point right atrium will be enlarged, for example, in the infant who comes with the tracheophalo, or rather in the neonate comes with tracheophalo or even Epstein anomaly, amongst the other conditions that we mentioned earlier. Echo is key. So indications for echo, a baby who comes with mama, okay, especially the pathological mama features that we said earlier. The one who has failed a hyperoxic test, okay, we not commonly done here, but I'll say one who has failed your pulse oximetry test. Features of hypoxia, hypoxic respiratory failure. You also need it if you suspect a PDA, send the baby, in other words, is that continuous mama on the left upper sternal border, send for evaluation. Do not start closing that PDA with our common non-steroidal anti-inflammatory drugs or even paracetamol. If there's differential saturation, as we said, between the right upper and the lower limbs, more than 3% after 3 measurements, or even blood pressure difference between the right upper and right lower limbs, in our guidelines, we even said of more than 10 millimeters of mercury, then send them for evaluation. Cardiomegaly on a chest X-ray. If there was an echo done during pregnancy and the concerns were raised, or there's a family history also of congenital heart defects, as we saw, be it in the father, on the mother, or even in the sibling, it's good to send for evaluation. Some of these are a result of mutations which can run in families. Initial supportive measures, just like the other neonates, ensure an adequate airway, oxygen, and mechanical ventilation. As I say again, if you suspect a critical congenital heart defect, don't try not to be so aggressive on the oxygen, because oxygen will result on its own into closure of that ductus arteriosus. Maintain the temperature. In our setup, we have radiant heaters, incubators for this. Fluids, initiate, especially in a NICU setting, inotropic supported, there is poor perfusion or hypotension. So if your systemic or mean arterial pressures are low, inotropes will come in hand. Fluids, again, you have to be careful. If the baby is in heart failure, in neonatology, you used to say at least 120 mils per kilo per day of IV fluids, don't go above that. Monitor vital signs, including saturations as well as blood pressure of both the preductal and postductal limbs. Monitoring and correction of acid-base imbalances. Monitoring and correction of hypoglycemia, hypocalcemia as well. Even during referral, ensure that the principles of neonatal transport are maintained. So if you are on fluids, if you are on oxygen, prepare and ensure that continued care is done as you refer to a terminal facility these babies. And again, we want to re-emphasize, when you sculptate and pick for a mama, don't close it blindly. You could be closing a key vessel, which is a key, as we saw earlier, in ensuring systemic, pulmonary, or in circulation, or in cases, or allow mixing in cases of separate and parallel circulations. Specific measures, prostaglandins. At Kenyatta National Hospital now, this is available. Prostaglandin E1, if you suspect a duct-dependent lesions, do not wait for an echo. You can start it off, okay? But as you start, monitor for hypotension, tachycardia. The babies can also go into apnea, or even they can develop neck as some of the other side effects. So if apnea develops, of course, intubation will be key during infusion. Then as you plan for an urgent echocardiography or an urgent review by a pediatric cardiologist, as well as intervention, subsequent intervention, or even surgery to ensure survival of the neonate. Cardiac catheterization procedures that we do depend on, of course, the underlying duct-dependent lesion. They are done to improve cyanosis, or rather improve circulation to the pulmonary or even systemic circulations. Some of the ones we do commonly at Kenyatta, for example, balloon atrial septostomy, where you create an ASD. You create a communication with an interatrial communication to ensure that there is mixing of blood now. And we do this commonly in babies with transportation of the great artery with intact intraventricular septum with or a restrictive PFO or a restrictive ASD. So you create it so that you see their circulations 40s or 50s, and they rise up to 80 once you do this procedure. Then, of course, you plan for a definitive surgery after that. Balloon valvoplasty. So this you balloon a stenosed valve, either pulmonary valve in critical pulmonary valve stenosis or a stenosed aortic valve. Again, this is available locally. Stenting of the ductus arteriosus as well, where it's closing, then you put a stent in the cath lab, in the catheterization lab, and that ensures there's continuous flow through the ductus to supply, for example, your native pulmonary arteries. In patients with pulmonary atresia with intact ventricular septum, in the cath lab, you can also create an opening to ensure forward flow from the right ventricular flow tract into the main pulmonary artery. And you do this by percutaneous balloon valvotomy. You open up that atretic area to and ensure that there is continued forward flow and therefore good pulmonary circulation. Then palliative balloon angioplasty. Here you balloon, especially in babies who present with coarctation of the aorta and they are not stable for surgery, either due to heart failure or they have not, of course, they may, or they have, and again, they have not responded to prostaglandins. So you in the cath lab, you balloon the coarctation area, then as you plan for a definitive surgery afterwards. We work well as a team with the surgeons, and with their help, we create also other palliative procedures, like a modified Blalock, Thomas, Townsend shunt, which we call a BT shunt, where in surgery you connect the subclavian artery and the right pulmonary artery, and that ensures that there is now flow into the pulmonary artery in situations where there is reduced pulmonary circulation, like the tetralogy of Fallot, severe RVOT obstruction, in pulmonary atresia, either with or without a VSD. And also another shunt which you can connect the aorta directly with the MPA, which we call a central or a Melbourne shunt. There are also other shunts, but these are the ones which are utilized in practice now. Then you plan for a corrective surgical procedure dependent on the underlying congenital heart defect. Prognosis: these babies tends to be at increased risk of developmental disorders, neurological impairment, and therefore disabilities. They also at increased risk of arrhythmia, heart failure, stroke, and even cardiac arrest. But early diagnosis is key to improve their survival. Early diagnosis, especially if we utilize our pulse oximetry, is very important in picking them out earlier and intervening earlier. One study showed that if you intervene earlier, the mortality rate within the first year is 16% compared to those who are diagnosed after they have left the hospital at 27%. So in summary, duct-dependent congenital heart disease are congenital heart abnormalities in which the patency of the ductus arteriosus is key to ensure systemic pulmonary or systemic or pulmonary circulations, or ensure there is mixture of the oxygenated and deoxygenated blood in situations of parallel circulations. Key in evaluation is the pulse oximetry tool. And of course, our clinical acumen or in history taking, in physical exam, and also early referral for evaluation and intervention is critical in improving survivals. And as I said earlier, do not offer them ibuprofen, paracetamol, or indomethacin to close that PDA blindly before you evaluate, before that the child should be sent for evaluation in a center with a pediatric cardiologist. I've come to the end of the discussion. I want to thank the big number of you who have been able to join this discussion. I also want to thank Kenyatta National Hospital for organizing this discussion on this very important topic. In this forum, I also have my teachers, Dr. Gashara, Dr. Njihia, Dr. Kimani, and other pediatric cardiologists who may have logged in to listen. So some of the questions that will follow, some of the additions, I'll welcome them to add and enrich this important topic. Thank you very much, Dr. Mkokinya.
Thank you, Dr. Barry, for that very informative and very well presented and clear presentation on duct-dependent lesions in the neonatal period. So we'll move on to the question and answer session. I think a couple of questions you already had answered as the presentation went on. So I'll go to the second question by Hailene, where she says, can aspirin used during pregnancy cause, I think, ductus arteriosus? I think maybe a persistent, a PDA. Sorry, let me just add on to that. Same, basically, what is the effect? Also, I think on the newborn when you give on giving aspirin on the PDA.
Use of NSAIDs basically is in the third trimester will likely cause ductus arteriosus intrautero, which will have fatal effects on the outcome of the fetus even before delivery. So NSAIDs ideally tends to be avoided during pregnancy.
This is Dr. Gashara. Let me add to that. We have not really used aspirins a lot, and there was a study sometimes back on trial of aspirin, whether it could cross PDA intrauterine, and now what was found was like it set pace for brufen. It didn't really cross the hemodynamic significant PDA in utero, but once the babies were born and they were given brufen, it crossed pretty fast. So it's probably low risk, unlike when you use paracetamol and brufen. Thank you.
Thank you, Dr.
I think for the questions, that is all we had. I think it was very clear and very well presented. Most of what I have are basically comments, saying that it was well detail-oriented, a very good learning forum, well-elaborate presentation, very smart. So mostly are just comments. So I don't know whether you have any, maybe Dr. Gashara, you can give us any additional comments, Dr. Njihia, Dr. Kimani, if you'd like to say anything before we allow Dr. Obare to give closing remarks.
Thank you, Daktari. The presentation has been quite clear. Maybe the only thing I would want to emphasize and re-emphasize is when you examine a baby and this baby is blue and has no respiratory distress, think cardiac. When you have respiratory distress, unless the PDA is crossing, usually it will be either sepsis or PPHN, persistent pulmonary hypertension of the newborn. But usually the cardiac will become when they are duct dependent blue until when it starts crossing, and they'll have the respiratory distress. When it comes to the systemic dependent region like the hypoplastics, just like Daktari emphasized, they'll be well until about the 4th day, where most of the PDAs now start crossing, and that's when they start having respiratory distress. So I don't think I really have much to add. It was clear and well presented, and the X-rays were classic. Thank you. Unless my other colleagues have something to add. But of course, the use of pulse oximeter, at least COVID blotters, pulse oximeters, let's try to use them. We will detect some of these children. Thanks.
Sorry, this is Dr. Njihia. I don't have much to add. That was a well done presentation, Dr. Obare. Thank you very much. I guess also just to emphasize that we should not be in a hurry to close the PDAs. When you hear that continuous murmur, you'd rather have an echo first because it could be a duct-dependent lesions. And actually recently we had a case of a baby with a TGA and had, before being referred, someone actually tried to close with brufen. So just to make us aware that, you'd rather have an echo first before giving anything to close the ducts. Thank you very much.
Just to add to that, Dr. J here, but this baby was blue. Why was PDA, why was brufen being used? A TGA baby is saturating 30 to 40.
Yeah, I can't answer that, but I guess we just need to emphasize that again.
Thank you for those comments, Dr. Gashara and Dr. Njihia. Dr. Kimani, would you like to give a comment?
So thank you, Daktari. That was an excellent presentation. I think what I would say is this just also highlights the value of pulse oximetry in the newborn. That every child, ideally, who's born should ideally not leave a facility without a pulse oximeter. It's a simple, important examination and investigation that would, point towards a ductal dependent lesion. Thank you.
Thank you, Dr. Kimani. Again, Dr. Barry, I'll let you give one comment. Just to close, any highlights, anything you'd want people to go home with, and then we will close the session.
I just to repeat again the last comment by Dr. Kimani, pulse oximeter. Let's utilize them. Let's utilize our pediatric cardiologists. Let's early referral is key to improvement of survival of these babies. Thank you again.
Thank you for that. You'll allow me to just mention one other question that has come in late, but I think it's very important about the administration of oxygen in cardiac patients. I think people want to know how much oxygen, when should we give oxygen, when should we not give oxygen. I think if you could just repeat that, yeah, it would be quite helpful.
A lot of many in our facilities of care, we tend to aim for very high saturations, 90, 95, or even more. I wouldn't really say how much to give, but if you suspect a critical congenital heart defects, then accept lower saturations, 70s or 80. I'll of course welcome additional comment by my seniors, rather than trying to either give with an under mask 15 liters of oxygen to be able to achieve, and most of the time you don't even get to achieve such targeted circulations, and the increased oxygen is known to promote closure of the ductors, and that then becomes detrimental to survival, or rather to the well-being of that baby. Dr. Gashara, if you have something else to add on that question, kindly you can comment.
Thank you, Dr. Obada. The question would be, why are you giving oxygen on this baby? Is it because of just low oxygen? Because like we've said, most of these babies will be calm. They're not in distress. So if the child is not in distress, saturations are low, you should suspect cardiac. And even if you give oxygen, you will not raise those saturations. And like Dr. Obare has said, if there is a duct which is helping that baby, then you facilitate the closure of that duct. So as long as the baby is calm, don't give oxygen. However, if they're in distress, you don't have to go to the 15 liters, 10 liters. If especially the saturations are not going up, because what Dr. Obare mentioned about hyperoxic test, that really defines cardiac respiratory. When it's respiratory and even give half a liter of oxygen, even by nasal prongs, the saturations just goes up. Cardiac, it won't change. So even if you go to 15, nothing much. So just give maybe to comfort the baby. Your 2 liters would be okay. But 15, 10, non-breather mask, even if you intubated, nothing will change. But the higher you give, the more tendency to cross the PD, which will worsen the situation. I hope I've answered the question.
Thank you. I think the answer is very clear. So I'd like to close the meeting. Thank you again, Dr. Obare, for that very informative, very well presented discussion. And thank you to the pediatric cardiology team, Dr. Gashara, Dr. Njiha, and Dr. Kimani, for your additional comments. Yeah, and thank you all for your participation and attendance. Nelson, if you have any comments regarding the CPD, I see that it's being it's trending. Yeah, if you have any comments, any announcements, I think you can go ahead.
Yes,
Thank
yes.
you again. Yeah.
Thank you as well to you and your team for this wonderful session. I think we've picked at 1,800 participants. That was good and everyone has appreciated. For CPD, KMPDC, we are uploading the lists to the ICPD portal, and the points will be awarded automatically from there. So keep checking on the status of your account to see the points you have accumulated. For PPB, we encourage you to subscribe to the sessions. We have uploaded all of this week's sessions. So kindly visit the portal and subscribe to the events, so to make sure not to miss out for any points that we will be awarding. We are planning to send out the tokens at least 2 days after an event. So kindly make sure your subscriptions are up to date. For NCK, points will be sent via your email, and they only have a validity of 48 hours. So kindly check your email throughout by tomorrow. The CPDs will be sent, and for COC, we will be sending the attendance list to the council for CPD awardance as well. Thank you for joining today's session and have a wonderful day. We will be having one extra session tomorrow on nutrition that is being shared right now on your screen. Kindly also join us for this session. Good afternoon.